Yes, Dr. Jog.
Dr. Pramod here.
Ah, good
What
evening,
time is the
sir.
meeting? What time is the meeting?
I don't know. They have started from 8:30. I saw it. So I
Yeah,
came.
yeah,
But
yeah,
actually nobody is there. Dhanalakshmi is there, I think.
yeah, yeah. I saw.
Good evening, Dhanalakshmi.
Acha, it has been.
Where are others? And what?
Hello.
Hello, आ गया.
Good evening, sir. We will be live at 9 o'clock.
अच्छा, live.
Ah,
So
So
then
we will start at 9,
for
9
some.
sharp.
अच्छा अच्छा ठीक है. तो
Okay.
15 मिनट्स के लिए बाय. कमिंग बैक 9.
So I
अच्छा,
just
वो
started the
वेडनेसडे
thing.
हो रहा है वो स्कारलेट फीवर.
वो करेंगे सर.
हो रहा है वेडनेसडे.
हाँ हाँ वेडनेसडे करेंगे.
अच्छा ठीक है. ओके फाइन. एंड हुआ द अदर. वो बाद में.
You बाला सर. You and बाला सर and राजू शाह.
अच्छा ठीक है. ओके ठीक है.
ओके. ओके मैं अभी थोड़ा बंद कर रहा हूँ. पेशेंट
ठीक है.
चालू है
आई एम
5-10
ऑल्सो
मिनट देख
गोइंग
लेता
आउट.
हूँ मैं.
9 बजे आएंगे फिर.
चेतन भाई सबका ओपीडी चल रहा है.
अरे हाँ सर थोड़ा लेट चल रहा है ना तो.
हाँ, नहीं नहीं ठीक है ठीक.
हाँ.
ओके. बाय.
9 sharp we will start.
ओके ओके बाय.
Yashwant sir, good evening.
Good evening, Dhanalakshmi.
Good
How are
evening,
you?
sir. Good evening, fine, sir. Fine.
All our panelists on. Yeah.
Yes,
Hello.
sir. Hello, sir. Good evening, sir. Dr. Rajkumar, sir.
Yeah, yeah. How are you?
I'm fine, sir.
Yeah. And hello,
Good evening,
Rachna.
sir. Krishna here, sir.
Yeah, yeah. How are you, Rachna?
Good, good, good. Just trying to finish my dinner before the meeting.
Great. Aram se. Don't worry.
Good evening, Dhanalakshmi madam.
Good
Vijay,
evening, sir.
good
Good
evening,
evening,
sir.
sir.
Good evening.
Good evening. Good evening, sir.
Hey, good evening.
Good evening, sir.
Sir. Good evening, Yole, sir.
Good
Good
evening,
Dr. Rajkumar. Good evening, Chetan, sir.
Good evening.
Good evening, sir.
Good evening. Very good evening.
Hi Vijay.
Hi.
Good evening, sir.
Yes,
evening, sir.
Secretary.
SBS sir, good evening.
Good evening, Jalil.
Good evening, all.
Good evening, sir.
Good evening.
Hello, sir.
Yes, the
Good evening.
great
Hello,
partner.
Buster.
Hi. Nice to see all the stalwarts in the upper case. Budding and budded, both.
Always batting.
When
Anyways,
Dr. Bala,
so
when Dr.
it is
Bala
9
is
o'clock.
around, one will not I mean,
Uh,
you need solution for
Dr.
everything.
Bhaskar,
Yeah,
shall we start?
yeah, please.
Because now, as such, Dr. Darur sir is not there, so you will be taking a place of chairperson elect.
Where is Dr.
Anyways,
Dararu?
yeah.
Where is he?
Good evening, all. Welcome to a second link of Super 11, a brainchild of Dr. Bala Subramaniam sir. And as we know that nowadays antibiotic resistance is really creating a big concern for all of us. So still people are just thinking that those people are in the practice, they are thinking that these are just the talks. It's not the real concern. And we know that is concern. And that's why antibiotic awareness was started, I think, long back in during the tenure of Dr. Vijay Yule sir. And he started a mission of AAA at that particular time. So now the awareness has come very high, but still we just would like to say how in OPD or IPD this concern can be tackled. So for that we have a brilliant panel with super expert moderator Dr. Vijay Yule sir. So I'll request chairperson elect of PIDA to welcome all on behalf of PIDA.
Yeah. Good evening, everyone. It is my honor and privilege to welcome you all to the today's great academic event. As Chetan told, it is a initiative by Dr. SBS and need of the hour. And with such a good topic, who else can moderate other than Dr. Vijay Vale? He is the right person you have chosen. And I welcome you, sir. Dr. SBS, sir. Welcome, sir. And all the panelists, of course, all the budding panelists and all are, they have done their, they have their expertise in the field of pediatric infectious disease and AMR. Dr. Rashna Rajkumar, Dhanlakshmi, and I think Nivedana, isn't it? Yeah. So I welcome you all and welcome all the viewers. And without wasting much time, let us start the program.
Okay. So a word of wisdom from Dr. Bala sir, please.
Thank you. Thank you. Let us get along with the program without wasting time. Thank you, Secretary. Yeah.
Okay. So we have a moderator, Dr. Vijay Yule sir. I think he doesn't require any introduction, of course. And we have Dr. Dhanalakshmi, then Dr. Rashna Das, Dr. Nivedana is a microbiologist, and Dr. Rajkumar, he's also ID expert. So over to you, Dr. Vijay Yule sir.
Well, very good evening, friends, listeners, viewers from the chapter. And I hope there'll be some other IIP members and DNB students whom I had shared the link. They would be joining this session. And with the panel of great experts, ID experts, and a microbiologist, I'm sure it's going to be a very interesting session. And more importantly, I feel so relaxed and relieved when I see Dr. Balasubramaniam on the in the group. So if there is any issue, any solution, there's one final answer. That is Dr. Bala. And I always say he's the greatest ID expert in the country and known for his teaching skills and most sought after teachers. And of course, Bhaskar is yet another ID expert. And I'm sure all of us collectively would put up a something which will be of utility to all practicing pediatricians, DNB students, and our viewers. So I have with me Dr. Rashna Das, Dr. Dhanalakshmi, and Dr. Rajkumar as ID experts and pediatricians, and Dr. Nivedana. Sorry for that typo error. She's not Nivedita, but Dr. Nivedana. She is a microbiologist. So I would spend a couple of minutes in this prelude that if you look at the history, the war between the man and the microbes, infections used to be absolutely life-threatening in the past. And we lived in what is known as pre-antibiotic era. And then came the antibiotic era when a lot of antibiotics were discovered, beginning with penicillin. And then infections became treatable. And there's so much of joy and overconfidence that man thought that, in fact, the Surgeon General, I would say retrospectively now, very arrogantly made a statement that it's time to close the books on infectious diseases. We I mean, as expected, despite the warning given by Sir Alexander Fleming, we went on using antibiotics irresponsibly. And the resultant, very much expected resistant emerged. And we have been pushed into what is known as post-antibiotic era with ever increasing, resistant pathogens. And this resistance runs across bacteria, viruses, fungi, parasites. And we are really having such a tough time that all the advances which medical science has made, they are on the verge of being nullified. Now, if you look at the statistics or projections, this is an old slide. Way back in 2016, it was projected that estimated that about 700,000 individuals die of resistant infections every year. It's a huge number. And it is estimated, it is envisaged that by 2050, we'll be losing about 10 million lives per year to resistant infection. And if you look at this diagram, AMR is going to be the biggest menace and number one, killer of mankind. So we need to find proactive solutions and we need to slow down this menace of antimicrobial resistance. Now, what goes wrong or what has gone wrong so far? Obviously, we know. I mean, I'm going to spend a little bit time on these basics because I see a lot of DNB students also joining this session. You have a colony of susceptible bacteria. Most of them are susceptible, use an antibiotic. The susceptibles get killed. What is left behind is resistant pathogen. So they have selection advantage and they start proliferating. And then it emerges, they emerge as resistant pathogen. And bacteria, unlike our human beings, are very friendly with each other. They would pass on this, trick to survive the onslaught of antibiotics. And this genetic material is very easily shared across the species from one generation to the next generation and across the species. And that results in antimicrobial resistance and spread of AMR. Now, epidemiological studies have definitely demonstrated a direct relationship between antibiotic consumption and emergence of antibiotic resistance. So it goes without saying that it is the antibiotic pressure which is one of the most important driver of antimicrobial resistance. So it is the misuse and overuse of antimicrobial which all of us indulge into that propagates antimicrobial resistance. Other than this antibiotic use, there are several other factors like lack of access to clean water, poor wash, that is water and sanitation and hygiene, poor infection control in healthcare facilities, poor access to affordable medicines, lack of awareness and knowledge, and lack of informants of legislation. We have a lot of rules and regulations. But even today, unfortunately, though there is a rule, irrational combinations are made available. They are available in the market. Antibiotics are available without prescription over the counter. And WHO year on hour takes cognizance of increasing AMR. And in 2011, WHO came out with the slogan that no action today, no cure tomorrow. And they identify list of pathogens which are of serious concern. And they have prioritized these pathogens which are critical priority, high priority, and medium priority. You have Acinetobacter, Pseudomonas, Enterobacteriaceae, Enterococci, Staph, Salmonella, Streptococcus shigella. These are to name a few which have been categorized depending on their menace into different categories. And I'm sure each one of us do come across these kind of infections and pathogens in our practice. And we need to understand one thing, that in the past, there was no resistance. Resistance started emerging, antibiotic pressure, and the resistance was thought to be confined to the healthcare settings. Now you see many resistant organisms, they come from the community, even in individuals or in children who are healthy, otherwise healthy, coming from the community. And you are really taken for a toss when you encounter resistant organisms in such children who come from community and get come for treatment to you. And I mean, all of us do understand that there are serious consequences of antimicrobial resistance. It leads to hospitalization, use of a lot of antibiotics, very often parenteral antibiotic, sometimes with fatal outcome. It leads to definitely a prolonged stay. It has economic impact. And we said that $10 trillion would be spent on fighting this menace. So with this prelude, Now, what I'm going to do is walk through a few case scenarios. We would start with very simple cases that we see in day-to-day practice in outdoor setting and go on to discuss little complex situations, talk of molecular methods of detection of resistance and the antimicrobial choice that we have for treating such infection. So here is my first case, and this is a 10-month-old girl who has fever, cough, and cold for 2 days and has left Autoria since a day. This child had received coamoxiclav 2 weeks prior to this episode of Autoria. No details are mentioned, but it's not an uncommon practice at all that your fever, cold, cough, and the child is given coamoxiclav. So what is the antibiotic that one would like to use in such situation? I would start with Dr. Rashna. And obviously, we do, so in a child who comes with autouria, one would definitely start an antibiotic. My question to Rashna is, how do you decide on empiric choice? What are the those cardinal questions that you must keep in mind when you decide to choose an antibiotic?
Thank you, sir. I think the first thing is, do we really need an antibiotic in this patient? Because the prodrome sounds like a viral infection. So we know that in viral infections, sometimes they do land up with otorrhea, and that could be just the virus induced. So the first question is, do we really need it? Second is, if we have used an antibiotic previously, was it for the right pathogen? And what is the severity of the infection? Does the child have any comorbidity? So those information would be required before we decide whether this girl will really require an antibiotic or not. Because
Yeah.
we know that I think the most common organism in such a situation would be a virus. Most of them would be viral, and this is only 1 year involvement. So it's not both years also.
Yeah. So what Rashna is saying is absolutely right. One needs to ask if an antibody is required. But by and large, the recommendations go that if you have an autouria, you would err on safer side and start an antibiotic. I totally agree with you that very often viruses can also give rise to otitis media. But a child with autouria, even if it is unilateral, there is a recommendation to start an antibiotic. And she very correctly said that these are 5 cardinal questions that one must ask. What is the probable pathogen? What is the site of infection, severity of infection? Are you expecting resistance upfront? And are there any comorbidities to decide on the choice of antimicrobial? So this is one must, I would request all the youngsters and DNB students to ensure that you learn this by heart, and this should be a practice. It should come at spinal level, that the moment you choose to use an antibiotic, ask yourself these 5 questions. What is the pathogen, site, severity, and this is going to dictate the selection of antibiotic. Now, having said that, Rajkumar, Rashna said that probable pathogen is one of the important decision maker in selecting an antibiotic. So, what pathogens would cause otitis media?
So Streptococcus pneumonia is the most common cause of otitis media. The other organisms include Moraxella and non-typable H influenza, which we do encounter at times.
Yeah. So very correctly said that we see a lot of viruses, but the major player amongst the 3 common pathogen is streptococcus. So much so that almost all, I'll not be wrong if I say that almost all otitis media are caused by streptococcus pneumoniae, unless you have associated symptoms indicating other pathogen like NTHI, where you always have, many a times you have associated feature like conjunctivitis, what is known as otitis conjunctivitis syndrome. Now, Dhanalakshmi, this is a child with autouria. We discussed the factors which would dictate our antibiotic choice. Now, I give you these choices. Amoxicillin 40 mg per kg per day.
So now our name,
High dose amoxicillin 80 mg per kg per day. Coamoxiclav 40 mg per kg, that's the standard dose, or high dose coamoxiclav, which is now very freely available in the market, 80 mg per kg, where the ratio of amoxicillin to clavulanic acid is 14:1 against the standard ratio of 7:1, and injectable ceftriaxone. Which of these antibiotics would you select?
here our target pathogen is Streptococcus pneumoniae. And we have to look at the risk factors for resistance. We know generally in non-meningeal isolates of pneumococcus, the resistance is very less. If you look at the Indian data also, the ICMR is yearly updating the guidelines. They say only less than 2% of pneumococcal isolates, especially non-meningeal isolates, are penicillin resistant. So the chance of the isolate being penicillin resistant is very less. So if there are no risk factors, then so there are some of the risk factors we should know, like younger age group that is less than 2 years, and if the child is previously exposed in the last 30 days to some antibiotic, or there is a daycare exposure, that is the chance of resistant pathogen is more. So if these risk factors are there, then you consider either the standard dose amoxicillin or the guidelines is to go for next dose amoxiclav. So everyone should know their own epidemiology. In our area where we are practicing, the penicillin resistance is very less. So I will look at the dose of amoxiclav the child has received previously. If it is a slow dose and used for 1 or 2 doses, I will ignore that and I will start with 40 mg per kg of amoxicillin with clavulanic acid.
And so that's a very important point that Dhanalakshmi has made. Two things she said. That one is most of the otitis media is pneumococcal. Two, she said that pneumococci in our country are still fortunately sensitive and susceptible to penicillin group of antibiotic. And she also said that this child having received coamoxiclav, a beta-lactamase inhibitor in past 30 days, this child received it 2 weeks ago. That would definitely influence the selection. So here one would anticipate or contemplate resistant pathogen. So you would like to cover for that resistant pathogen. And then she also made a point that if you are in daycare-like setting, the risk of the pathogen being resistant is reasonably high as compared to a child who is not exposed to such environment. So one would use a standard dose penicillin if the child has only a couple of doses of coamoxiclav. If he's received coamoxiclav, then one would definitely anticipate resistance and use coamoxiclav. Dhanalakshmi, you said that the non-meningeal isolates are sensitive and we do have intermediate resistance which can be overcome by increasing the dose of pathogen. Suppose if I tell you that this child had received coamoxiclav only for a day, the exposure was not significant, would you consider using high dose amoxicillin in this child? And there is no conjunctivitis. So my suspicion for pneumococcal otorrhea is extremely high.
When I look at my hospital data also, we had last year 49 isolates. Among the non-meningeal isolates, penicillin resistance was negligible. So in places where there is high incidence of penicillin-resistant pneumococcus, then only the high dose amoxiclav, that is amoxicillin 80 mg per kg with 14:1 combination is advisable. Other places, standard dose amoxicillin is more than good enough. And amoxicillin has an excellent penetration. Middle air fluid concentration is very good.
Yeah.
So I think I will go for standard dose.
Well said, Dhanalakshmi. These are a few things that one needs to keep in mind. If you look at the standard textbook, which are written by Western, authors, where the rate of penicillin resistance is very high, they would recommend high dose amoxicillin or high dose coamoxiclav. Whereas in India, the pneumococci are still susceptible, and one can treat these children with standard dose amoxicillin. And if at all you are thinking of covering for resistant, Hib or Moraxella, one could use standard dose amoxiclav. So at this point in time, let me quickly recapitulate.
Only one thing I want to emphasize here, sir. So most of the time what happens is, so there is 14:1 combination available. That should be given only if they prefer to use 80 to 90 milligram per kg per day of amoxicillin. Sometimes they choose to give 50 to 60 and they choose this combination. So it is like negligibly giving clav. It is like only giving amoxicillin. So that point they have to remember. Every day the mistake is happening.
Absolutely, very well said. So I will quickly come to that after I go through this algorithm. So let us quickly go through the recommendation that IAP has endorsed so far. You have mild disease in a child below 2 years. If the disease is bilateral, you start with amoxicillin. If there is no improvement, you treat it as probably Hib or Moraxella contributing to the failure, and you would cover this resistant Hib or Moraxella by adding beta-lactamase inhibitor. So change from amoxicillin to coamoxiclav. If it is unilateral, as Rashna said, very often it is viral, and mild disease can also be self-limiting. So you would wait, and if there is no improvement, you would start amoxicillin, and then if it fails, you will go to coamoxiclav. As against that, if the disease is above 2 years, again, mild disease, one would wait. And as against that, if the disease is very severe with explosive onset fever of 103 plus, you would definitely upfront start co-amoxiclav. Now, this is what has been recommended. Now, there has been a lot of discussion on high dose amoxiclav and the need to start co-amoxiclav in severe disease. So recently, a group of pediatrician experts and ENT surgeons, they had a consensus statement. And what has been proposed is all otitis media except otitis media conjunctivis syndrome, which are by and large caused by pneumococci, and pneumococci being sensitive in our country, these children should be treated with standard dose amoxicillin. So regardless of severity of the disease, the starting antibiotic should be amoxicillin. If it fails, then you use high dose amoxiclav. This is done with the thought process that a child who has failed on amoxicillin, by changing to high dose amoxicillin and adding clavulanic acid, you achieve both the things. You cover a possible beta-lactam producing Hib and Moraxilla, and also take care of the intermediate resistant Streptococcus pneumoniae if at all it is there. Whereas a child who has otitis media conjunctivis syndrome, and or if he has been exposed to beta-lactam in the previous 30 days, your starting antibiotic would be standard dose amoxiclav. And if that fails, you start high dose amoxiclav. Now, this is too simplified sort of algorithm or practice tip given by this group, which would be published very soon as Delphi consensus. And ideally, if your standard dose amoxicillin fails, and having said that the otitis media is primarily caused by pneumococci, one could also indulge in increasing the dose of amoxicillin. And if that fails, you switch over to high dose amoxiclav. So, but this is too difficult to put it as a recommendation for general guidelines. So what has been proposed is you start with amoxicillin regardless of severity, except in otitis media conjunctivis syndrome. If it fails, you switch over to high dose amoxiclav. Now, here is the point that Dhanalakshmi was trying to make, that in standard dose amoxiclav, the ratio of amoxicillin clavulanic is 7:1, whereas in high dose, it is 14:1. So very often when we calculate the dose, a mistake is made. And since there is 600 milligram per teaspoon of per 5 ml of amoxicillin in high dose amoxiclav, this preparation is used, where the clavulanic acid delivered is suboptimal. So please take care of it into practice. Now, having said that, Nivedana. Yeah, Rashna.
Dr. Yole, I mean, when you say that there is no improvement, so it is 24 hours, 48 hours, or 72 hours?
48 to 72 hours. 72 hours is the 48 to 72 hours is the recommendation that is made. Yeah. Now, Nivedana, having said that, what is the mechanism of resistance in Streptococcus pneumoniae? Mike will come to our rescue now. Yeah.
So the mechanism of penicillin resistance is in Streptococcus pneumoniae is penicillin binding protein alterations. So that is the major mechanism of resistance. And the important among the pneumococcus has 6 types of penicillin binding proteins. The important one is PBP2X, sir. And as Dr. Dhanalakshmi madam had said, the resistance is dependent upon the MIC breakpoint, sir. So generally, the MIC is different for meningeal and non-meningeal isolates, sir. So for meningeal isolates, the MIC of less than 0.06 is only considered susceptible because the penicillin has to cross the blood-brain barrier and reach the target area. Whereas for non-meningeal isolates, an MIC of greater than 2 is only considered resistant, sir. So less than 2 is susceptible. So most of the non-invasive isolates fall within the susceptible range for us.
Okay. So again, for the listeners to understand, let me repeat it, that penicillin, Streptococcus pneumoniae continues to be sensitive. The resistance mechanism by alteration of penicillin binding protein. And among the 6 types, PB2 is the important, PBP. And she said that you have meningeal isolates and non-meningeal isolates. The breakpoints have been revised for non-meningeal isolates, or for meningeal isolates. anything which is less than 0.06 is taken as susceptible. And for meningeal isolates, anything above 2 is taken as resistant. In fact, 2 is intermediate and 4 is resistant. So by increasing the dose of amoxicillin,
For
especially,
meningeal, there is no intermediate,
there is
sir.
no intermediate, absolutely.
Yeah, less than 0.06 is sensitive and greater than 0.012 is resistant.
Absolutely. So by increasing the dose of amoxicillin, one can overcome this intermediate type of resistance. And that's why in non-meningeal cases, one could try that high dose amoxicillin. But that perhaps will not take care of all resistant pneumococci, especially when it is meningeal isolate. And that is the time when we need to add vancomycin. So this is what she was talking about in the revised criteria, breakpoints for non-CNS or non-meningeal isolate. Sensitive is anything below 2, intermediate is 4, resistant is 8. Whereas in CNS, only 0.06 and below is susceptible, and there is no intermediate category, and anything above 0.12 is resistant. I am repeating this because pneumococcal infections are the commonest bacterial infection that we come across in practice. And there's a lot of confusing literature, and different pediatricians tend to follow and different guidelines. And so we are trying to clarify the issue again and again. Now, we also
One more
talked
thing I
about,
want to add, sir.
yeah, Dhanalakshmi, please.
Since the mechanism of resistance is the alteration in penicillin binding protein, adding BLA, that is clavulanic acid, is not going to help in pneumococcus.
Absolutely well said by
Most of the
Dhanalakshmi.
times we will get a culture, but we don't have the guts to de-escalate. So clav is not going to help in pneumococcus. That point they should carry.
Yeah. So this is one reason we are trying to get into the details of the mechanism of resistance, that it is penicillin binding protein alteration. So in this case, adding a beta-lactamase inhibitor is not going to help at all. Whereas, Rashna, you have these 2 other pathogens which also cause upper respiratory infection, bacterial infection like sinusitis and otitis. So what is the mechanism of resistance in Hib and Moraxella? Rashna?
I think her signal is not there.
She's not there. Nivadena can take it, or any one of you can answer.
Yeah. So literature-wise,
So these are mostly because of, hello?
Yeah, Rashna, please.
Hello?
Yeah, Rashna, please go
Yeah,
ahead.
yeah, you can hear me? Yeah.
Yeah.
So for Hib and Moraxella, it's mostly a beta-lactamase which is in action. So that is the reason why it is different from pneumococcus.
Yeah.
So there we'll have to use something else.
So you overcome by
beta-lactamase.
adding a beta-lactamase. So coamoxiclav, it is stepped up to coamoxiclav for this reason, to cover the resistant Hib and Moraxella. And the other way that you can overcome is a third-gen cephalosporin. Third-gen
So
cephalosporin by themselves can overcome beta-lactamase. Now, this is the breakpoint that we have discussed in detail. Nivedana very beautifully elaborated to it. Now, let us move on to the next case. This case has been shared with me by Dr. Dhanalakshmi. So I'm going to ask Dhanalakshmi or maybe Rajkumar to comment on this patient. This is a 1-year-old boy, has been vaccinated till date, has been having fever for 4 days. There is cough and fast breathing for 2 days. No distress, but or no hypoxia. Is able to maintain saturation in room air. Counts are elevated, neutrophilic counts. Hemoglobin is 10.4, platelets are 2.3, and CRP is very high. And you see kind of a lobar pneumonia in this child on the right side. So Rajkumar, what is going to be your choice of antibiotic?
So here is a boy with a short duration illness, a short duration lower respiratory illness, having a consolidation. It's likely a community-acquired pneumonia. For community-acquired pneumonia, still pneumococcus is a predominant cause, though other infections like non-typable H influenza can occur. Still, pneumococcus will be the main pathogen.
Yeah. So I have purposely projected this, chart again, saying that these are the 5 things that this should come reflexly. Pathogen, site severity, resistance, comorbidity. And this is a patch where the child is able to maintain saturation room air. We have decided to treat this child on outdoor setting. The drug of choice should be amoxicillin. But friends, unfortunately, pediatricians seem to have lost faith in amoxicillin, compounded by problem of erratic availability, that we tend to use either third-gen cephalosporin or coamoxiclav. And I'll talk about it, how they are inferior. Now, Dhanalakshmi, you shared this case with me, and you have projected this. This child blood culture was sent, and this is what it yielded. Can you quickly talk about the?
Unfortunately, they're able to isolate pneumococcus. And if you look at carefully, so they have So the lab doesn't know whether it is a meningeal isolate or non-meningeal isolate. So they have given the MIC and break point, even if it is a meningeal isolate, how to interpret. If it is a non-meningeal isolate, how to interpret. So if you look at, we know it is a non-meningeal isolate. So for penicillin, MIC is only 2. So as per CLSA, it is sensitive. So if it is penicillin sensitive, we can very well use amoxicillin.
Absolutely. So the laboratory will tell you in details. It is a good practice that in Chennai you are getting breakpoints also. Many laboratories do not tell you the breakpoints. So again, quickly I have put the chart up for the revised guidelines for breakpoint for pneumococci. Now, let us now quickly understand. Nivedana is there with us. What is this MIC and breakpoint business? Many pediatricians shudder to think of this. And so tomorrow you have a report where you have MIC and a pathogen, and there are several antibiotics. And how do I go about selecting from amongst those which have MIC, which is within the range of susceptibility? So can you elaborate a little bit on MIC and breakpoint and what is this therapeutic index? Nivedana.
Sir, MIC is the minimum inhibitory concentration of the antibiotic, which is achievable in blood, that inhibits the growth or prevents the multiplication of the organisms. Breakpoint is the MIC. The breakpoints are given for both for MIC and for distribution methods of sensitivity testing. So it is used to categorize the organism as sensitive dose dependent, intermediately sensitive, or resistant. And therapeutic index is nothing but there is always a susceptible breakpoint category in CLSI. And here, like we have seen in the above example, every lab reports with the actual MIC. So therapeutic index is calculated by dividing the susceptible breakpoint by the actual MIC of the current isolates. So further it is low, like how far it is low from the current MIC is low from the breakpoint, then it is good that then it implies that the organism will be very much susceptible to that antibiotic. So higher the breakpoint by MIC ratio, it is better, sir, provided the antibiotic attains the concentration pertaining to the site of infection and all the intrinsic resistance mechanisms are ruled out.
So, Nivedana, I believe that these breakpoints and MICs are pathogen, the drug and bug specific, right?
Yes, sir. Yeah.
Absolutely.
So there is no need to memorize it. It is the duty of a good microbiology lab to give it the MIC along with the breakpoint. Without the breakpoint, just giving the MIC alone is of no clinical significance. So it is just going to confuse the doctors viewing it.
Absolutely. So Nivedana being a micro, it's so easy for her. It is at the tip of her tongue. And I'm sure pediatricians have followed it, but for the sake of my fellow pediatricians, I have prepared this simple, schematic, slide where minimum concentration of antibiotic that inhibits bacterial growth is MIC. Highest concentration that can be achieved in the patient to define susceptibility is your breakpoint. And the antibiotic susceptibility is tested by adding serial dilution of the drug to the broth. So imagine these are the test tubes or the dish, and you go on adding serial dilution 0.06, 0.12, 0.2, 0.5, 1, 2, 4, 8, 6, and then 32. Now you just imagine that there is a pathogen for which MIC is 0.12. And an antibiotic for which the MIC is 0.12 and antibiotic B for which the MIC is 1 for a particular pathogen. And for this pathogen, if the breakpoint is 2, you could use either this antibiotic with MIC of 1 or this antibiotic with MIC of 0.12. However, as Nivedana said, further the MIC away from breakpoint, better it is. It is extremely effective. So if you calculate, this breakpoint would define susceptibility. MIC below the breakpoint is susceptible. MIC, which is closer to the breakpoint, is intermediate. So intermediate is MIC is approaching the breakpoint or on the breakpoint, whereas MIC greater than breakpoint is resistant pathogen. Now, if you calculate therapeutic index here for this drug A, where MIC is breakpoint is 2 and the MIC is 0.12, breakpoint divided by MIC is 16.6. Whereas for this antibiotic B, the MIC is 1 and the breakpoint for this pathogen is 2. So the therapeutic index is 2. So obviously higher the better. So in this case, one would use the antibiotic A, where therapeutic index is higher and the MIC is quite away from the breakpoint, as against the antibiotic 2, where the MIC is close to the breakpoint. And like again revising the pneumococcal sensitivity, for meningeal isolate, anything below 0.06 is taken as sensitive. Anything for non-meningeal isolate, anything below 2 is taken as sensitive. And that is how we decide selection of our antibiotic. And as Dhanalakshmi said, ICMR has very clearly, it keeps on updating the data, and it says that beta-lactams are preferred over microlides because they look at the resistance, and even the ICMR CAP guidelines would recommend amoxicillin. Now, Dhanalakshmi or Rajkumar, very often we see third generation cephalosporin as being used for treatment of pneumonia. How do you rate amoxicillin against third generation cephalosporin? Do you think they are superior to amoxicillin?
Because pneumococcus is the most common pathogen, I think simple amoxicillin more than enough. Ceftriaxone appears to be a broad spectrum for pneumococcus, because there we also end up to cover for H influenza, moraxella, etc. like that. So amoxicillin as a single type will be the best option, even it's going to be severe pneumonia.
Yeah, and what one gets tempted to use is the available oral third generation cephalosporin. But as I have shown on this slide, that cephalosporins have shorter half-life, they're absorbed poorly as compared to amoxicillin, and they're highly protein bound. So they are dosed at 12-hourly interval. And these beta-lactam antibiotics act by, they are time-bound antibiotics, time-dependent killing they achieve. So one has to have MIC well above the drug levels well above the MIC, and to achieve the time-bound killing. And from that angle, amoxicillin scores over cephalosporin. So the antibiotic, the pathogen has to be exposed for adequate time to the antibiotic so as to become effective. Now let's move on to this case. 3.5-month-old infant, fever for 3 days, irritable and refusal to feed. Irritable, bulging AF, and you have made a diagnosis of acute meningitis. Counts are high, neutrophilic count. You have done a CSF, it shows pleocytosis, again 72% neutrophils, and sugars are low. Sugar serum, CSF to serum sugar ratio is altered, suggestive of acute bacterial meningitis with elevated proteins. Rashna, what is going to be your antibiotic choice in such patient?
Well, here again, I think we have to look at the organism. So probably pneumococcus is the pathogen which is causing the infection in this 3.5-month-old. We already saw in our previous discussion that there is for the meningeal isolates of pneumococcus, we know that the MIC is higher. So yeah, so it's different from the non-meningeal isolates.
True.
So here we will use probably will use a cephalosporin, and it still works in meningitis. But there are studies which have shown that there are some increasing resistance only to cephalosporin. So there is a recommendation nowadays that along with this, we should use an additional drug that like vancomycin. So I think that is what is the recommendation now. So here in this choice, I think we'd go for the last one, that is ceftriaxone plus vancomycin.
Okay. So very rightly said that is acute meningitis. And again, the big three causing community-acquired meningitis beyond neonatal age group are strep pneumonia, Haemophilus, and Neisseria meningitis. Now, Neisseria and Haemophilus are susceptible to third-gen cephalosporin. But as Rashna said it rightly, that, and as we saw in the past discussion, that the breakpoints for meningeal isolates are reduced to 0.06. And so meningitis being a very severe infection, one cannot take a chance, and one would definitely upfront think of this and try to cover for this possible pneumococcal resistant pneumococci and add vancomycin. So there is data supporting this, leading cause being pneumococcus. Though the overall resistance to pneumococci in India is low, This is a publication on CMC Vellore, which clearly showed that the blue line is indicative of penicillin, whereas the red line is for the third generation cephalosporin. Way back in 2008, it was in the range of about 10%. It has increased to 42.8%, the non-susceptibility to penicillin. Similarly, for third generation cephalosporin, from 5%, it has gone up to 30%. Now, having said that, one needs to think of this and add something that would take care of this possible, non-susceptible pneumococcus in such a child. And that is what compelled the IAP also to change its recommendation from only ceftriaxone in the initial days to ceftriaxone plus vancomycin in the treatment of, as empiric choice in the treatment of acute bacterial meningitis. Again, ICMR has data, and it also recommends use of ceftriaxone plus vancomycin for treatment of acute bacterial meningitis. So, Dhanalakshmi, again, thank you for sharing this case. And again, Dhanalakshmi shared the data on the blood and the CSF isolates. It grew meningitis, and it was raised. The MIC was 2, and the penicillin it was resistant to penicillin also. So Dhanalakshmi has been lucky that she could retrieve the report, and the isolate was very often in clinical practice. You start empirically with vancomycin and ceftriaxone, and the culture is negative. One unfortunately ends up continuing vancomycin. One must try and resort to molecular methods and try and establish a diagnosis. If it gives a definite pathogen, one can definitely tailor the therapy accordingly. So now let us go on to this case. Rajkumar, this is a 3-month-old girl, and had otorrhea again, and somebody has sent the pus for culture, and it has grown pseudomonas. And this pediatrician is very culture savvy, very rational pediatrician. Now, having grown pseudomonas, what will be the antibiotic of choice in this patient?
Yes, sir. For a 3-month-old to develop otitis media along with otorrhea, still pneumococcus is the most common cause, though other organisms like non-typable H influenza and Moraxella can be. But the best fluid to be sampled is a middle ear fluid, but it's also difficult sampling. So culture showing pseudomonas, we need to be really concerned what we are dealing with. If it's going to be otitis externa or a CSOM, probably pseudomonas can be considered. But otherwise, we should need to cover for pneumococcus mainly.
Extremely well said by Rajkumar, that ideally one should look at the myringotomy sample to know the true pathogen causing the otitis media in a child. But that's not practiced. However, it is an incorrect practice to send the swab from the leaking ear or discharging ear. And very often the pseudomonas that you grow is not a true pathogen. It could be colonizer, or as he said, that it could be, otitis externa. And one may end up in trouble by misinterpretation. So while empiric therapy is the therapy that we very often indulge into, definitive therapy is definitely superior to empiric therapy. However, interpretation of reports and results is extremely important, and one needs to be cautious when applying this and selecting an antibiotic. Dhanalakshmi, this is
Sir, can I just add to this? In the previous case of ear with pseudomonas, I think the only time when we have to really seriously consider if the patient has some comorbid condition. Because
absolutely.
if you look at
Immunocompromised child, yes. Immunocompromised child would, it's a different ball game altogether, and one would think of. But at the same time, it's a double-edged weapon. In critically ill children and immunocompromised children, we tend to over investigate, and we tend to play it safe. And this is one big area where a lot of irrational investigations and irrational antibiotic use happens. Anyway, let's leave that aside. Dhanalakshmi, this is a 7-year-old child, pain in throat for 2 days, sandpapery rash. And I'm sure many of my colleagues across the country must be saying there is an outbreak of streptococcal sore throat going on. At least in Mumbai and November, we see a lot of streptococcal. In last 1 month, we saw a good number of cases. And RADT is positive, and we have made a diagnosis scarlet fever. So which of these antibiotics will you use, Dhanalakshmi?
Amoxicillin, sir. Group A streptococcus has never developed resistance to penicillin. This we should remember. Again, in pharyngitis, there is no need to add clavulanic acid. Only plain amoxicillin should be used. And the dose is 50 milligram per kg per day. Maximum is 1 gram per day. And there is significant proportion of resistance to azithromycin. And there is no need for clavulanic acid here.
But so this is again extremely simple case to diagnose and very common case. We will not discuss that very often non-bacterial sore throat are treated with antibiotic, but even amongst those who have definite indications, clinical and otherwise of a bacterial tonsillopharyngitis, lot of antibiotic abuse happens. As she said very correctly, it is caused by Streptococcus pyogenes and it is universally susceptible to amoxicillin. So one need not use any other drug. And the dose also she mentioned, and the duration is 10 days. We aim to eradicate the pathogen from the throat. So use it for 10 days. One gets tempted to use azithromycin for the shorter course of duration of therapy and once a day, use of azithromycin. But azithromycin, you see a lot of resistance among Streptococcus pyogenes. And this is it can be as high as 30%. This is one of the publications that we made from Navi Mumbai, and we looked at an outbreak. And during this outbreak setting, 4 isolates were resistant. So it came to about 30%. We had 12 patients where my molecular testing was done, and the genomic testing revealed that these isolates were resistant to macrolide. So please refrain from using azithromycin, and there are several other reasons why azithromycin should be used sparingly. We'll talk about it a little later. Rashna, 10-year-old boy, high fever, abdominal pain, limping on the right side. Right hip movements are painful, and he's in that FFD, fixed flexion deformity. CBC shows high counts, neutrophilic counts, CRP is 110. And we got a sonography done, it showed psoas abscess. And there was about 13 cc of psoas collection. And again, antibiotics.
So I think here in a psoas abscess, the most common bacteria would be staph. So in staph, the ideal drug to be used is a cloxacillin. And if that is not available, then probably most of the time we'll end up using ceftriaxone. So if cloxacillin is there, then that would be the drug of choice.
Yeah. So
And
yeah, Rashna, please go ahead.
yeah. So since it's a psoas abscess, so all this will be like, intravenous drug.
Yeah. So my dear experts and viewers, please don't get annoyed at this repeatedly flashing this blue, flag. But this is what I keep on saying repeatedly. This should come reflexly. Pathogen site severity resistance comorbidity. And as Rashna said very correctly, it is the Staphylococcus, the commonest pathogen responsible for psoas abscess. So in the absence of availability of first generation cephalosporin, that is sizolin and cloxacillin, this child was started by the pediatrician co-amoxiclav, and there was steady improvement. Child became afebrile on day 5 of co-amoxiclav, and the blood culture grew MSSA. We did not aspirate this psoas abscess. The parents were not willing, and the child was successfully treated with co-amoxiclav, and there was complete resolution of psoas abscess. So the message that I wish to give here, though the predominant resistance seen in Indian isolates is in gram negative and gram positive was not very high many years ago. Over the period of time, even the resistance among gram positive cocci is on the rise. Initially, it was the problem of Western world, but India also has started seeing a lot of, MRSAs. However, even today, most of the community infections are MSSA, and cloxacillin, as Rashna said, is the drug of choice. It is better than anti-MRSA drug. Between vancomycin and cloxacillin has superior kill when it comes to killing MSSA. Clindamycin is useful on necrotizing infection, and cefazolin is another drug which can be used, but again, unfortunately, the availability is a little erratic. Now, Rajkumar, this is a child who has, who this case again was shared by Dr. Prakash Vaidya of Mulund, and this child had such a, pouring pus from the umbilical stump. So what would be your antibiotic?
There's a newborn with the omphalitis. There's a frank pus discharge. Possibility of MRSA could still be there, though MSSA can also be there. So because it's a sick child, I will think about starting parenteral antibiotics. I'll go for both cefotaxime along with the vancomycin initially, and based on cultures, I will de-escalate.
Absolutely. So there are recommendations that though it is mostly staphylococcal, polymicrobial infections are known with omphalitis. So those staph being the commonest one, And as you put it very correctly, that in a newborn baby who is sick with such pus pouring out, you would try and cover for MRSA also. But then that decision very often is depends on the local epidemiology. To our not exactly to our surprise, but we had cultured this pus and it grew MSSA. The purpose of putting up this case is very often we tend to mistake virulence and severity with resistance. Remember, even sensitive bug can cause severe or virulent infection. Not necessarily that every severe infection is caused by a resistant pathogen. Now, Dhanalakshmi, let me come back to another case which is on the screen. 6-month-old child, fever for 5 days, excessive sleepiness. The child is irritable, poor feeding, tachycardia, elevated counts, high CRP, not very high, 36, and blood culture is sterile. And this is what the MRI showed. Because one of our residents could sense that the child had difficulty in swallowing, and we put in a tongue depressor, there was bulge on the left tonsil. So we suspected some collection there, and this is what the MRI showed. So what antibiotic?
We'll start on ceftriaxone clindamycin.
Why?
Again, the pathogen. So it could be MSSA or MRSA. And Haemophilus influenza in the 6 months, a very young infant. So still we know what it is. So we'll start on ceftriaxone and clindamycin.
Yeah. So looking, if I were to tell you that this was a 6-year-old child, would you still think of a gram-negative or Hib?
Older children, I will not think of.
You would think it will be only staphylococcus, but
Yeah.
in such a severe infection, you would start parenteral antibiotic and you would upfront cover for MRSA, right?
Yes.
So we tried to aspirate this under sonography, and aspirate culture showed MRSA. Now, Nivedana, for a pediatrician, can you quickly tell us how do you make out from the report that the isolate is MSSA or MRSA?
MSSA and MRSA, we report based on cefoxitin sensitivity, sir. So cefoxitin is a surrogate marker to determine the methicillin susceptibility of Staph aureus. Previously, oxacillin was used, but due to the difficulty in performing this diffusion test, the commonly used methodology in microbiology, we have shifted to cefoxitin. So if cefoxitin is reported as susceptible, then it is MSSA. Or if cefoxitin is reported as resistant, it is MRSA, sir. But good labs always convert the cefoxitin susceptibility into methicillin susceptibility on the reports in order to avoid confusion.
Okay, so very well said, pediatrician, fellow pediatrician. Please remember, oxacillin or cefoxitin is taken as surrogate marker, and if it is resistant, you take it as MRSA. Now, Nivedana, I looked at the report. It also mentioned that it was resistant to clindamycin, sensitive to vanco and linezolid, but resistant to ciprofloxacin and cotrimoxazole. So what does that mean?
It is resistant to many of the non-beta-lactam antibiotics apart from the MRSA. So it could be a hospital-acquired MRSA.
Yeah. So this was surprisingly a child who came from the community, had peritonsillar abscess, and the isolate was like the healthcare associated MRSA. It was MRSA and like healthcare associated MRSA. Now, having said that, let me also caution all my pediatrician friends that both CA, MSSA and MRSA coming from the community have similar disease spectrum. So on the face of it, it becomes difficult to differentiate a susceptible staph from a resistant staph. And MRSA, very often, I mean, these pathogens do not have good response to beta-lactam. And if you have exposure to beta-lactams in the past or recurrent infection, you are clustering in the household, one could have very high index of suspicion for community-acquired MRSA. But on the face of it, at times it can be difficult to say if the pathogen is MSS or MRSA. Dhanalakshmi, 9-month-old girl, fever, cough for 2 days, and the child is breathless. There is right consolidation with fluid. And what are the pathogens here?
I would like to cover pneumococcus and staph. So everyone should know their own local epidemiology. So that is very important. So if you take child test in our hospital, if you take 100 isolates of Staphylococcus aureus, around 40 to 50% are MRSA. So in a sick child like this, so I would like to empirically cover both MSSA, MRSA. Then once you find the organism, then maybe if possible, we can de-escalate. So maybe I will start on ceftriaxone Clinda again.
Okay, fine. So, I mean, she is very correctly said that you would want to cover these pathogens, strep pneumoniae, staph, streptospirogenes also, of course, and H influenza, and the antibody that would cover
H flu.
flucloxacillin, which is not again available everywhere. It's a little costly antibody. Clindamycin is also a good alternative. Now, having said that, this child was started on this. We put in an ICD, and this is what was yielded. It was sent for culture. The smear showed gram-positive cocaine clusters and in pairs. Nivedana, what do you make out of this? Clusters and pairs, both are present. So is it a dual infection, strep, pneumonia, and staph?
No, sir. In direct gram stain, Staphylococcus aureus can occur as singles, pairs, clusters, and tetrads. So,
Absolutely. Thank you for that clarification. So this was a pure staphylococcal growth and culture was awaited. And the child continued to spike despite good ICD and good drainage. And we received the culture sensitive report. And by this time, Nivedana had trained me how to read the report. And this report showed that we know that staph are MRSA or MSSA, and MRSA can be healthcare associated coming from the community. So this child was oxacillin resistant. So it was MRSA, and it was cotrimoxazole resistant, vanco and linezolid sensitive. And as she taught us in the previous case, this was healthcare associated MRSA. But it was clindamycin sensitive. So Dhanalakshmi was very right in advising clindamycin to this child. Now we know there are certain risk factors for contracting healthcare associated MRSA. Rasna, would you like to take this up? What are the risk factors for healthcare associated MRSA?
Yeah, I think the first is if there has been any hospitalization in the past for any serious infections and the child has received antibiotics for a staph infection in the past 3 months. The second is if the patient has stayed in a hospital setting for a long time. So they get infected by more resistant bugs from the hospital. And if there is some prosthetic device or a medical device, for example, you have a catheter which is there in patients getting chemo or even a valve in some patients. Similarly, if there is a previous surgery, and of course, if they have come in contact with a patient who has suffered from a methicillin resistant Staphylococcus aureus infection. So all these are very, very important when we consider the risk factors. But I think nowadays we are, as you have already previously said, even without the risk factors in the community itself, we are getting straight away the methicillin resistant Staph aureus. So it's very difficult to say.
No. So absolutely, this is what we have been taught and we have been trained about, that these are the risk factors for association of healthcare associated MRSA. But if you look at the case that I showed you just now, none of the criteria was fulfilled. And we do not know whether the child came in contact with the MRSA case or not, but none of the previous 4 or 5 risk factors were present. So this child was healthcare associated MRSA from the community. And as Rashna said it very correctly, that these days you get MRSA and resistant pathogens coming from the community. So once upon a time, confined to the healthcare setting, these organisms have jumped to the community and we see healthcare associated coming from the community. If you look at the evolution of resistance among gram-positive cocci, penicillin was very effective. They started producing beta-lactamase. We came with cloxacillin and beta-lactamase inhibitors and first generation cephalosporin, which could take care of this staphylococcus, but they became resistant. MRSA was born. We discovered vancomycin, and we know that there are vancomycin resistant staphylococcus aureus. And over the period of time, vancomycin has become really very blunt and ineffective. More anti-staph antibiotics were invented, and sometimes in the 1990s, late 1990s, this MRSA started coming from the community also. So Staph aureus is MSSA or MRSA. MRSA could be healthcare associated, where we saw that these are the risk factors which are usually associated, or community acquired MRSA, where they are genetically different, they have different, Nivedana told us that they have a different antibiotic susceptibility pattern, and the risk factors are absent. However, this distinction between HA-MRSA and CA-MRSA is no longer distinct, and we saw in these two cases that even the healthcare associated kind of antibiotic susceptibility pattern can be seen in a child who has MRSA infection, who has come from the community. So nowadays, what we call, divide this MRSA into healthcare onset, hospital onset or community onset MRSA. So regardless of their, antibiotic susceptibility pattern. And health hospital onset are isolated 48 hours after admission, and community onset would obviously come from community but have antibiotic susceptibility pattern like your healthcare associated MRSA. So the distinction between HA and CA is diminishing, and there is a revised terminology, HO and CO, and not HA and CA. And the community acquired are genetically different. There are different cassette chromosomes involved in the two types of MRSA, and the community acquired are usually, they manifest with skin and soft tissue infection or necrotizing pneumonias, whereas HA-MRSA can cause all sorts of staphylococcus infection. And as I said before, the antibiotic susceptibility, the CA-MRSA fortunately are amenable to treatment with agents like doxycycline, clindamycin, quinolones, and cotrimoxazole. So one needs to remember this distinction and the different susceptible pattern which Nivedana has tried to teach. Now, quickly talking about anti-MRSA agents, we have vancomycin, linezolid, teicoplanin, daptomycin, clindamycin. Dhanalakshmi, can you quickly run us through this anti-MRSA agent?
Three bactericidal drugs: vancomycin, teicoplanin, daptomycin. Teicoplanin convenient use, once daily dose, but still not FDA approved. So most of us tend to prefer to use vancomycin. Daptomycin in places where you cannot use vancomycin, like there is a renal impairment, you cannot use. So in that scenario, and it is currently approved for bacteremia and right-sided infective endocarditis also. So we can use these daptomycin. So linezolid and clinda both are bacteriostatic and both have antitoxin property. And as far as possible, preserve linezolid. This is a good anti-TB drug, so preferably not to use linezolid upfront.
Yeah, thank you very much.
And once you plan to use clindamycin, check for inducible clindamycin resistance. They will report whether it is positive or negative. If it is not there, then upfront you can use. So for that, you have to look at the erythromycin sensitivity. If both erythro and clinda are resistant, we are not going to use. If both erythro and clinda sensitive, we can very well use. If there is a discordance in sensitivity, then you look for the D test, that is inducible clindamycin resistance. If positive, you are not supposed to use clindamycin. If negative, you can use clindamycin.
Yeah. So thank you, Dhanalakshmi, for bringing out that point. The D test you saw on the slide, that you put erythromycin and clindamycin disc besides each other. And on the side of erythromycin, there is flattening of the zone of clearance. That indicates that there is inducible resistance to erythromycin. So in such a situation, you would not use clindamycin. Nowadays, most of the laboratories would directly give you MIC, and then they did not perform the D test, and from that you can make a choice. Rajkumar,
Yes, sir.
this is a 1-year-old girl. So far we discussed the resistance among gram-positive cocci. Let's look at some gram-negative infections. 1-year-old girl, high fever for 2 days, urine shows packed-filled pus cells, high WBC and high CRP, culture awaited, ceftriaxone started, culture comes back at ESBL E. coli, and patient afebrile by the time report comes. Now, what are we dealing with? What is this?
So here is a child with a complicated UTI, probably a pyelonephritis. She is coming from the community. Here in ESBL, ESBL rates are high in the community. We expect almost 60 to 80% of the E. coli are ESBL. So empirical choice itself would have been piperacillin and tazobactam, and we shouldn't have gone for ceftriaxone. And based on culture susceptibility, we can always de-escalate. Though ceftriaxone has been used in this child, there's a chance of failure happening after therapy, and the child can again come with a relapse, a recurrence of UTI. So ideally, should go for an agent which is covering for ESBL.
Yeah. So again, a point of debate, or there could be a differing opinion. Very often we get complicated UTI and we start ceftriaxone as an empiric choice. And by the time the report is made available, it shows extended spectrum beta-lactam is producing pathogen, and the patient has responded. So as Rajkumar very correctly said, here the chance of relapse are very high if you continue to persist with a beta-lactam antibiotic, knowing that the strain is, extended spectrum beta-lactamase producing strain. However, one must also remember that the sensitivity is something which is tested in vitro, and beta-lactams are highly concentrated in the urine. So very often they are able to overcome this in vitro resistance and the patient responds. So some people do prefer to continue and treat the patient and not the report. But there is a school of thought that having recovered a definite ESBL pathogen. Now, having said that, one needs to be careful that the urine collection is done with a clean catch method and it is sent to the laboratory in time, and there is significant bacterial colony count. So there is a school of thought that you should go by the antibiotic susceptibility pattern report and treat accordingly to prevent recurrence or relapse. So we saw
We can do that. Sometimes, if this scenario, most of the time we tend to say, but amoxicillin, some oral drug will be sensitive. Even if it is an ESBL producer, amoxicillin or sometimes Ceptron, something will be sensitive. So you can quickly switch to that sensitive drug and you can get away with them.
Yeah, so that is another point that Dhanalakshmi has made. If you look at this, these reports, very often there is sensitivity to co-amoxiclav or even cotrimoxazole for that matter. So one could definitely quickly switch over to this kind of agent. I absolutely agree with you. Nivedana, in the previous cases, we saw that strep pneumonia, penicillin binding alteration protein, Hib Moraxella beta-lactamase, and we could overcome it by beta-lactamase inhibitor and ceftriaxone. Now here we saw something E. coli, which produced what is known as extended spectrum beta-lactamase. So can you quickly tell us what is this all about?
Extended spectrum beta lactamases are mostly plasmid encoded enzymes, sir, which confer resistance to the first, second, third, and the fourth generation cephalosporins. But most of the times it is there are a multitude of enzymes. So, but these will be regularly inhibited by clavulanic acid, tazobactam, and sulbactam. But having said that, I want to add a note of caution that there are certain inhibitor-resistant extended spectrum beta lactamases are also there. Like CTXM we are having, that is resistant to inhibition by tazobactam and clavulanic acid. So all the time we have to be guided by the sensitivity report.
Yeah. So very beautifully explained in very short time by Nivedana. So we saw that penicillin binding alteration in strep pneumoniae, beta-lactamase production by this gram-negative pathogen. And if you all recollect, in the past, we used to treat even E. coli UTI with amoxicillin. But now these pathogens have learned to produce what is known as extended spectrum beta-lactamase, making these antibiotic, even the third generation cephalosporin, ineffective. So one needs to use, higher generation beta-lactamase inhibitor. So these are rendered ineffective. And additional BLBL like piperacillin, tazobactam, cephalosporin, sulbactam, or carbapenems may have to be used in such situation. Now, Dhanalakshmi or maybe Rashna, 5-year-old boy has acute abdomen. Explorative laparotomy was done. Klebsiella pneumonia resistant to third generation cephalosporin identified. I was empirically started on ceftriaxone, was changed to piperacillin tazobactam. There is no improvement. Source has been controlled. Antibiotic changed to meropenem. So what must have gone wrong here? Why did piperacillin? We saw in the previous slide that you have ESBL, which can be overcome by piperacillin tazobactam, but here it failed. Why must have it failed?
So there could be two reasons. One is that you have used a bolus dose of the piperacillin tazobactam, because we know that if you give it as an infusion, it stays longer in the blood and acts better. That's the pharmacodynamics and kinetics of it. The second could be the mechanism of resistance could be different. So this could be a different way the resistance has occurred, and that's why it has not responded to your piperacillin tazobactam. So there is a group of organisms which actually has the AMC beta lactamase. So that will not respond to your piperacillin tazobactam.
Yeah, so very correctly said by Rashna that there is a group of Enterobacteriaceae which do not respond to even the higher generation beta-lactamase inhibitor, because they are not only ESBLs, but they have a different beta-lactamase production called AMC beta-lactamase. So typically the spice group, Serratia, Pseudomonas, indole positive Proteus, Citrobacter, and Enterobacter, this spice group of pathogens are notorious for production of AMC-beta-lactamase, rendering even the piperacillin tazobactam or cephalosporin sulbactam ineffective, and one needs to resort to carbapenem. So this is how gradually over a period of time, organisms have made antibiotic useless. Beta-lactam production by H. flu, E. coli, gram-negative pathogen, beta-lactamase combination were used by us. They overcome it by producing extended spectrum beta-lactamase. More BLBLI were invented like piperacillin tazobactam, cephalosporin sulbactam, and now they have learned to produce AMC-beta-lactamase, where even the higher BLBLI are made ineffective, and we have to resort to agents like carbapenem. So
Sir,
third
one
gen
more thing, sir.
cephalosporins are
One more,
yeah, please.
one more reason, sir. So the peptide failure may be due to the another concept of inoculum effect. If the load of organism is high, the MIs of the organism may be more. That is a new concept they are telling. That is why recently, I think in 2022, CLS has increased the MIC breakpoint point for piperacillin tazobactam. So now look at the isolates. Now even most of our ESBL E. coli from the urine, some of the most, like nearly significant proportion, they are reporting as resistant to piperacillin tazobactam. So the famous Merino trial, if there is a bacteremia due to ESBL group of organism, they compared BLBLI versus carbapenem, and there is a slight mortality like benefit with carbapenem. So that is why if it is a ESBL bacteremia, the drug of choice is now the carbapenems, because there may be undiagnosed, unchecked other beta lactamase may not have been picked up, and the other concept of inoculum effect.
Okay, so what Dhanalakshmi said was the ESBLs are overcome by piperacillin tazobactam. In that particular patient with acute abdomen, it failed. So one of the reasons could be AMC, but the other reason she says could be the inoculum effect. Now, Nivedana, what is this inoculum effect? Nivedana?
Inoculum effect simply means the bacterial load, sir.
Yeah.
If the bacterial load is low, then it can be overcome by the BLBLI inhibitor like Cryptas, sir. Whereas if the bacterial load is high, especially in cases of bacteremia, it is always better to go for the carbapenem.
Correct. So on one hand, we said that in vitro cell, even if the pathogen is resistant, by hyper concentrating the drug at the site of infection, one could overcome that in vitro resistance. At the same time, there is something called as inoculum effect, where the laboratory may show sensitivity, but when the bacterial load in vivo is extremely high, the antibiotics may fail to cure the patient. Fine. Thank you for that clarification again. And so ESBL cannot be overcome by, treated by third gen cephalosporin. So, and the AMC beta-lactamase producers cannot be treated by BLBLA combination. So we need to resort to using carbapenems. And this is extremely important to remember. I'm sure Dr. Nivedana would agree with me that very often you have multiple, mechanisms of resistance present in one, pathogen or one individual. And
Yes.
like what has been depicted beautifully here by this picture of elephant, and then there is a, horse or a dog and a cat and a mouse. If you look at the large, you tend to miss the other in the picture. So one is to be extremely careful and look at, and there are limitations in the laboratory which may fail to detect all sorts of, mechanism of resistance present. Nivedana, would you like to add something to this?
Yeah, sir. As you rightly said, the isolate could be just a simple ESBL or AMC producing isolate, but because of the other antibiotic mechanism of resistance, like efflux or porin loss, it might appear as carbapenem resistance even without the production of carbapenemase.
Absolutely, absolutely. So this I'll quickly skip in the interest of time, that you have a lot of gram-negative pathogen coming from the community, and this is the slide depicting different mechanisms of action like enzymatic inactivation, which is the commonest among gram-negative pathogen, beta-lactamase and various beta-lactamases production. It could be modified target alteration in penicillin binding protein. It could be the plasmid, a chromosomal genetic thread carrying the mechanism of resistance. It could be modified cell wall or cell membrane, or as Nivedana was just mentioning, there could be an efflux pump where antibiotic, the moment it enters there, it is thrown out by the efflux pump and making it ineffective in a particular pathogen. I'll just quickly go through
Efflux pumps are a major problem with the tetracyclines and the gram positives. and for the carbapenems in Pseudomonas aeruginosa, especially the meropenem.
Yeah. So please remember these practice pearls, as Nivedana said, that especially in pseudomonal infection, your carbapenems may fail because it may not produce carbapenemase, but there could be efflux and the antibody is thrown out of the cellular system. I'll quickly run through this wrong practices that many of us are still indulging into. NICU, precious delivery, given cefotaxime. Exposure to third generation cephalosporin is one of the most important risk factor for development of resistance. Dengue fever, plasma leakage on IV ceftriaxone. It's a common practice to give IV ceftriaxone to every admitted patient to a nursing home. Falciparum, though there is an indication to start antibiotic in severe falciparum malaria, every child of malaria gets polytherapy. Fever without focus, without indulging into making an attempt to establish diagnosis, child is put on ceftriaxone amic acid. That's the standard pair of antibiotic which is used in very often in many nursing homes, and very often the sore throat that we see in clinical practice is garden variety viral infection, but very often treated with oral third generation cephalosporin. Now, this is what I was talking about. Dhanalakshmi was mentioning that Dhanalakshmi, suppose you grow an ESBL pathogen, what are the treatment options available?
So if it is a urine isolate, definitely it can be overcome by beta-lactamase inhibitor like amoxicillin, cefepime, sulbactam, or piperacillin tazobactam. So BLBLA should be enough. So if it is not working, like the spice group. So even though we mentioned the spice group, now the IDSA current guidelines, they mention only the 3 group of organism. That is Enterobacter cloacae, Klebsiella aerogenes, and Citrobacter frundi. These 3 organisms are definitely capable of producing ANSI. So definitely you should upfront go for carbapenemase. Or if you have failed, like BLBLA is not working, then we are going to go for carbapenems. So the main advantage is the carbapenem, if you use, it is a serious infection, we can directly use for like bloodstream infection. Because of ESBL producing organism, we can use carbapenem. So main thing is it is stable against ANSI producer and there is no inoculum effect. So in the minor situations like where there is a urinary source or whether there is a biliary source and you are able to source control, then BLBLA can be the drug of choice.
Yeah. So absolutely well said by Dhanalakshmi that there is enough literature evidence to say that the outcome is not favorable if you use only BLBLI in serious and severe infections. It is better to resort to carbapenems. Now look at this patient, Rashna, perforated appendix, peritonitis treated with cefepime sulbactam. The child is operated, source is controlled. The child was on short ventilation, but the child is stable and afebrile. And many nursing homes, unfortunately, continue to have this bad habit of sending tracheal cultures. Tracheal culture was sent and it grew Pseudomonas, which was sensitive to meropenem. And so this child was put on colistin, meropenem. What happened is, would you change every patient who grows Pseudomonas from the tracheal culture?
No, I think here we have to understand that, first of all, why was it sent?
Yeah,
If you're sending it, then you have to have a reason for it. Did the
absolutely.
child throw a fever? No. The child was stable, child was improving. So I think the very concept of sending the tracheal culture is wrong. Because most of these patients, when you have a indwelling catheter inside, like a endotracheal tube or even a urinary catheter, they are bound to get colonized by some organism. So I think what they did here was they got the colonizer and they treated the colonizer. So I think it was very unnecessary. And then again, after that, you get Pseudomonas, which is sensitive to colistin. So I think, I hope the patient was not given colistin, because again, this would just be if the patient is totally asymptomatic, it means that we were just treating the report, not the patient.
So,
We
Rashna,
were looking at the colonizer.
this is what I was mentioning, where diagnostic stewardship is extremely important. In ICU settings and critically ill children, we tend to overdo. And this tracheal aspirate grew Pseudomonas. Patient was shifted to meropenem. Patient had no fever whatsoever. And now patient started developing fever, counts went up and developed pneumonia. And the repeat tracheal culture now sent, it should have been sent earlier, as you said very correctly. Now the Pseudomonas sensitive only to colistin. So an important important antibiotic was wasted to treat colonizer. So Rashna has made extremely important point that one needs to have a reason to ask for an investigation, and one needs to definitely differentiate a colonizer from a true pathogen. So carbapenem resistance is again on the rise, and as Nivedana said, it could be efflux working in the pathogens like Pseudomonas. Many of them produce beta-lactamases. There could be porine channel, because they enter through the porins, and it's becoming a menace. What happens? You use antibiotic, the antibiotics fail. You tend to use carbapenems, and the moment you expose patients to carbapenem, there is an inherent itch amongst the pathogens to develop carbapenems. Now, Nivedana, could you please take us through this slide of beta-lactamases?
Sir, simply put, there are two types of classification: Ambler and Bush-Jacobi-Medros classification. One is the structural, other one is the functional classification. Here, the beta-lactamases, we will first go through class C, sir. Class C doesn't have a carbapenemase at all. It has only AMC producing beta-lactamases. Other than that, class A, class B, and class D, all the three have ESBLs as well as carbapenemases. In that, class B is simple. It is metallo-beta-lactamase. It is zinc dependent, sir. So, in our Indian setting, the main problem is the metalloenzymes in both E. coli, Klebsiella, and as well as the Pseudomonas and the Acinetobacter. And class A and class D. Class D is present mainly in the Acinetobacter and few of the enterobacterials. It contains the oxacillinases. And it also contains the few carbapenemases, but then it is difficult to detect that by conventional diffusion methods. You have to have a high index of suspicion to detect the class D carbapenems. So ertapenem, any ertapenem MIC greater than 0.5 microgram per ml, you have to suspect a carbapenemase is there. Class A enzymes, it contains both the ESBLs and the carbapenemase. The carbapenemase here is the KPC. KPC is not much of the problem in India. It is a problem in Western countries. Whereas in India, the main problem is the MBL, which contains the NDM, WIM, and IMP.
Okay. Thank you so much, Dr. Nivedana. Again, some of my pediatricians who are viewing this session may find it difficult to memorize and remember unless they are into routine practice. But remember that you had gram-negative pathogen where simple antibiotics worked. They started producing beta-lactamase, then extended spectrum beta-lactamase, AMC beta-lactamase. The more the antibiotic they were exposed to, they learned to overcome by producing more enzymes or finding some different mechanisms of resistance. And these are the beta-lactamases classes which are present. Your ESBL would belong to class A, and as she said, that it is metalloenzymes which are extremely important in India, which require zinc for their activation, and it is metallo-beta-lactamase, the notorious New Delhi metallo-beta-lactamase, which is a chromosomally mediated resistance mechanism, which is rendering many ICU pathogens resistant, and sometimes the outcome is unfavorable. Class D, also known as OXA48, and there are different varieties of OXA, AMC. And one thing that you must realize from this slide, that there are a few, resistance mechanisms which are carried by plasmid. And chromosome would be translated from one generation to the other, where plasmid can, traverse across the species. So plasmid can really be notorious. And when we say Enterobacteriaceae, we mean Escherichia, that is E. coli, Klebsiella, Enterobacter, Citrobacter, Salmonella, and Shigella. And there are three different classes of the gram-negative resistant pathogens. Then you have Proteus and Serratia, and these are put as Enterobacteriales. So Enterobacteriales have these three families, and these Enterobacteriales produce carbapenemas, which is now nowadays most of those who are practicing ICU are recognized as CRE organisms. So this is what I was mentioning to you. With every passing year and day, we are producing more and more antibiotics, and microbes are producing more and more ways and tricks of overcoming this antibiotic. And this saga continues. Increase ESBL, excess use of carbapenem. Carbapenemase is produced. Excess of colistin and colistin resistance is also very rampant. And initially it was chromosomally mediated, and now you have, way back in 2015, a plasmid mediated colistin resistance was discovered. So chromosomal mediated, plasmid mediated, we have already discussed, and we published this paper, Danyal and myself, long back, where we documented that there's a lot of resistance coming from the community as well. Let's move on to this case, Rajkumar. 10-year-old boy, dengue shock syndrome, ventilated. The child starts spiking while the child was improving, and blood culture is sent, and it shows since the child was spiking, antibiotics were changed from ceftriaxone to piperacillin tazobactam. The lab calls up and says they are growing some gram-negative pathogen, and identification and susceptibility would take some time. And the child does not improve, continues to throw spike, requires fluids and inotropes. What should be done at this point in time? Should we change from piperacillin tazobactam to meropenem, or we wait?
So
Rajkumar?
here is a child who has been hospitalized, has developed a hospital-acquired infection, a gram-negative infection. The chance of carbapenem resistance is definitely going to be high as compared to ESBL organisms. So here I will think about covering for carbapenem resistance. I will think about a broader spectrum like ceftazidime, avibactam, aztreonam, or colistin-based therapy.
So, for what Rajkumar is trying to say is the hospital-acquired gram-negative infection, and as Dhanalakshmi, Dr. Nivedana said that metallo-beta-lactamase and CRE organisms are increasingly found in ICU setting in India. He says that he would like to upfront cover with ceftazidime avibactam. Now, Dhanalakshmi, would you agree with him, or would you give a trial of meropenem here?
No, actually, again, you should know your local epidemiology. In your ICU, if it is Pseudomonas acinetobacter is common, I will go for colistin-based therapy. Otherwise, I will resort to some molecular diagnostics. If you send the result, you are going to get the results in 4 to 6 hours time. So maybe at this point of time, I will escalate to carbapenem and I will send the carba-R test. Okay, any carbapenem resistance. And based on that, if needed, we can modify.
Okay, so we did what Dhanalakshmi said. We changed from piperacillin to meropenem. Lab informed us that it is Klebsiella pneumoniae. Sensitivity is awaited, and we asked for expert carba-R, which is capable of detecting these many enzymes, and it detected NDM. And so the antibiotic was changed to ceftazidime avibactam plus aztreonam, and the child improved. And when the antibiotic sensitivity test was made available, we realized that the meropenem MIC was more than 16. So Rajkumar was right that given the hospital setting and the kind of resistance that we see in our setting, anticipated
Avibactam and aztreonam will not cover Pseudomonas and acinetobacter. So till we know E. coli or club, it is better to go for colistin-based therapy rather than Septa avibactam plus aztreonam.
Absolutely.
So once you know it is E. coli or club, then we can proceed.
Yeah. So fellow pediatricians, what Dhanalakshmi said is acinetobacter and Pseudomonas would also come as under gram-negative, isolate. And unless we know that what we are dealing with, one would try to give colistin-based regime, and only after the definitive results are available, one would tailor the therapy. And as she very correctly put that there are molecular methods which are available now and which would detect, which would help us, tailor the therapy. So,
in fact, one more thing is if Malditoff is available, once the GNB flagged, that can be sent for Malditoff. We can get the organism and ID simultaneously.
Now, most of the bigger hospitals, they have a Malditoff with them, and it has really made life much easy. Identification can happen very quickly. So phenotypic, you send the specimen for culture. The moment it flags something, you do Malditoff, and you also run molecular test, and that helps you to identify the pathogen and know the precise antibiotic susceptibility, and you tailor the therapy.
It takes 48 hours to change our antibiotics. So this within evening we can change.
Absolutely.
One more add-on point, sir.
Yeah.
The main notorious organism in this case is Klebsiella, which has about 40% of carbapenemase production. So you can always call the microbiologist on the lab and check, because Klebsiella grows very fast. It's an organism which is a lactose fermenter, a mucoid, and any lay person would be able to identify it easily. And most of the blood cultures which are flag positive will have a growth in around 6 hours maximum. So the moment you see Klebsiella, it is always safer to change to ceftazidime avibactam and aztreonam. So
So that's an important tip that Nivedana has given us, that you correspond with the
Not
laboratory.
for all patients, only for ICU sick patients.
yeah,
Yeah.
only for ICU patients. Yeah.
Obviously. So now, with the permission of my experts, I would love to show these slides, which I'm thankful to Dr. Balaji, who was kind enough to share with me. I thought these are important take-home slides, which would help all the pediatricians who are dealing with resistant pathogens to know what is happening in India and what is the best way of treating them. So what he said in his oration in Vellore last year is ESBL, obviously they confer resistance to penicillin, cephalosporins, and Monobacterium aztreonam. They are inhibited by piptase, amoxicillin, and ampicillin. Whereas AMC, even this group is ineffective. So you could use cefepime. Cefepime is nearly stable. And carbapenem definitely would take care of AMC producer. Carbapenem resistance, you club your pathogen in the enterobacterials and other organisms. So you have carbapenem is producing enterobacterials and carbapenem resistant enterobacterial, where the mechanism is different than production of enzyme. Similarly with other pathogens. So you have CPE, CRE, CPO, and CRO. Then he also said that he spoke specifically about the gram-negative pathogens in India. So India, most of the E. coli are ESBL producer. They also measured almost half of them have oxa production. 15% are carbapenem resistant. So, and they are metallo-beta-lactamase positive. And only 2% colistin resistance seen amongst E. coli. As against that Klebsiella, that the case that we saw, and as Dhanalakshmi also said, that it is usually NDM and OXA48 like producing carbapenem resistant strain, and you must talk to the laboratory, and it grows very quickly. And Dhanalakshmi also Nivedana made a point that KPC though is being talked about a lot in literature. In India, KPC is not our problem. KPC, if you remember, is group A carbapenem is Klebsiella pneumonia producing carbapenem is. Pseudomonas Dhanalakshmi has been time and again talking to us about mechanism other than enzyme production. And when you suspect Pseudomonas, your carbapenem may fail. And Pseudomonas and Acinetobacter, these are two notorious organisms where one needs to be extremely careful in planning your therapy. And this is what can be tried in E. coli or Klebsiella pneumonia. If you want to have carbapenem sparing regime, use piperacillin high dose or extended infusion. It is recommended to avoid this BL-BLI combination in sepsis where you have very high inoculum. And the alternative is cephalosporin sulbactam. AMC enterobacterial bacteria use cefepime if the MIC is low. In high MIC, again, because of inoculum effect, cefepime may fail. Colistin sparing options for carbapenem resistant E. coli. We already talked about E. coli can be managed with ceftazidime avibactam. However, Klebsiella will produce New Delhi or NDM like resistance, where one will have to add aztreonam to the combination of ceftazidime avibactam. Outside our country, ceftazidime aztreonam combination is available, which is not there in our country. And cefiderocol is another antibiotic, which unfortunately is not available to us. I would skip this doses.
One more thing, sir, that ceftazidime avibactam plus aztreonam has to be given a simultaneous infusion, that they should remember.
Yes.
We want aztreonam avibactam, not ceftazidime.
Yeah.
Since the combination is not available, we are using that.
Absolutely. So simultaneous administration of both the agents. Nivedana, he also spoke to us about the synergy testing. Can you quickly talk about synergy testing?
Synergy testing is that ceftazidime avibactam, you're going to test two antibiotics together to counteract the problem of all the types of carbapenemases. So here ceftazidime avibactam and aztreonam are tested most commonly by the strip stacking method or the disc elution method. So both of the antibiotics, when tested alone, can be resistant, but then when they are tested together, they give a sensitivity, higher sensitivity.
Yeah.
So it's prudent to use them both. So for the carbamazepines belonging to the classes A and D, we can still get away with ceftazidime, avibactam, BLBLI inhibitor, whereas the MBLs, the only BLBLI inhibitor doesn't inhibit. So you have to add the astrione.
Yeah. So very well said. And then when you perform the synergy testing, one needs to look at the breakpoints also. As Dr. Balaji has very beautifully simplified and put on this slide, that only when the breakpoint is below 4, you call it susceptible. A higher breakpoint will make the antibiotic not work, and it would fail when given to the patient. And this is what he talked about. I think in the interest of time, I'll quickly go through a very common problem that all of us see. Rashna, I would want to ask you that you have a child who has culture positive Salmonella typhi, and I started on IV ceftriaxone, but day 5 the fever persists. So what are the possibilities?
I think in this case, it's just taking a longer time for the patient to respond. If
Okay.
the typhoid, if the bacteria is sensitive to it, then probably we should just continue. We
Okay.
know that salmonella takes some time to respond clinically.
Yeah. So how do you proceed in that case? You just continue, the beta-lactam ceftriaxone and wait for the fever deference, right? Uh,
Yeah. If the
because,
patient is stable, there is no other problem, then we just wait because
yeah.
it's written in textbooks that it takes a long time to
Now,
respond. So
yeah,
we would not be in a
yeah.
hurry.
Rajkumar, are you seeing case of ceftriaxone-resistant typhoid in your region?
No, sir. Fortunately, we don't have ceftriaxone resistance. Our Indian strains are still susceptible to ceftriaxone, and ceftriaxone can be given as an initial therapy.
Yeah. So ceftriaxone resistance, fortunately, has been, coming sporadically. We had a few cases a few years back in Mumbai. This year, we heard about ceftriaxone resistant typhoid fever from Ahmedabad and Baroda. And but fortunately, the outbreak has not lasted and has not spread to other parts of the country. So we are very lucky that it is still low. So do you add antibiotic if the defervescence is long, Dhanalakshmi, or you stick to
No
monotherapy?
single drug only, monotherapy only. As of now,
Monotherapy.
only monotherapy.
Okay. Okay. So obviously, friends, you must remember that these children who have culture-prone enteric fever with susceptibility proven on, report, be patient, wait for the defervescence to occur, and don't hurriedly jump to changing the antibiotic. And pre-antibiotic era, the CFR for typhoid is very high. During antibiotic era, the first line of therapy, that ampichloro and cotrimoxazole, brought down the CFR to below 1%. But one fine morning in early 1980s, all of the agents started failing, and we developed what is known as MDR. And uh, it's something which is not a good to have be proud about. This Clade 58 originated in India, and we spread it to the globe. And fortunately, fluoroquinolones came to our rescue that time. And but then again, as we use fluoroquinolone left, right, center, and very soon the salmonella learned to mount resistance to fluoroquinolone. And fortunately, third generation cephalosporin and macrolide azithromycin and carbapenem came to our rescue. However, all of us are pretty well aware of the XDR typhoid outbreak that we saw in Pakistan in 2016. And so the XDR typhoid in Pakistan is probably, chromosome or plasmid mediated. And it is said that from other gram-negative pathogen like E. coli, the plasmid has passed it on to the salmonella. Now, my question to Nivedhana, how about azithromycin? How good is it for treatment of enteric fever? And what is so special or peculiar about azithromycin?
Azithromycin has a very good, it belongs to macrolide class of antibiotics, sir. And the plus point about azithromycin is that it's a very good intracellular penetration, and the concentration of the azithromycin inside macrophages, inside which the salmonella resides, is usually 50 to 100 times higher than the serum levels. And the time for fever clearance is quick with azithromycin. That is, the time for fever defervescence is faster, and the relapse risk is also less. And it has the convenience of once daily dosing also.
So, Dhanalakshmi, is it safe to use it once a day or you prefer to use it twice a day in enteric fever?
Fairly only, sir.
Okay. Now, Nivedana, I want to know about the breakpoints for azithromycin, like ceftriaxone or any other beta-lactam. Do we have well-defined breakpoints for azithromycin? Can you say that an MIC of so and so is susceptible, or MIC of or zone clearance of such a diameter is definitely susceptible?
There's very less limited clinical data correlating with that is the breakpoints with the clinical response, sir. But the CLSI has come up with distribution and zone diameter for susceptibility for azithromycin for Salmonella typhi alone. The MIC of less than 16 microgram per ml or a zone size of greater than 13 millimeter is considered susceptible. But having said that, the zone is very narrow. That is, the zone size of greater than 13 mm is susceptible, but less than 12 mm is resistant. So there could always be an individual reader bias and things like that. The way in which you have to perform the susceptibility of distribution should be very stringently controlled, sir.
Yeah, so there is no linearity. I mean, not necessarily that in vitro resistant may not work in a patient because azithromycin is known to be concentrated several fold in intracellularly. But at the same time, Rajkumar, have you seen azithromycin failing? Can it fail?
Yes, sir. So far, I have not seen any case of azithromycin resistance. But again, because of the increased use of azithromycin usage, there is high probability that we may start failing with azithromycin. So next drug of choice, which we may be need to start using is cotrimoxazole. In fact, in chances where azithromycin fails, cotrimoxazole will be the drug of choice.
Now, Dhanalakshmi, I want to ask you one question that Rajkumar said in case azithromycin fails, we still have, now we have stopped using cotrimoxazole, ampicillin and chloramphenicol. Chloramphenicol, of course, is a given up drug. And there was an issue of Lancet which mentioned that chloramphenicol should be relegated to dustbin, should not be used in pediatric, given the side effects profile that it has. Now, if because the antibody pressure is lifted, many salmonella are becoming susceptible to these first line agents. So how safe would it be to use cotrimoxazole? Would it quickly develop resistance on exposure to cotrimoxazole? Will it recur again very quickly?
I don't know, sir. As of now, sensitivity is very good. 98% they are showing susceptibility, cotrimoxazole.
So do you use in your clinical practice? Do you use cotrimoxazole?
Not at upfront status.
Not.
Yes.
So
we do use cotrimoxazole in older patients, sir. The problem with the first level of drugs like ampicillin, cotrimoxazole, it's going to be the relapse rates. So we need to treat them properly. We need to follow them properly. Unlike azithromycin, the relapse rate may be a little higher as compared to azithromycin.
So yeah, so one is relapse and the second is, I guess that the moment you start reusing these agents, the salmonella is quickly going to mount resistance, and the old, though apparently looks to be proving good, may not be good for a persistent period of time. Rashna, if you look at the sensitivity report of salmonella, every patient of salmonella is sensitive to amikacin. Can you use amikacin?
I think it doesn't give any added benefit because when you already have another drug which is working, then amikacin, I mean, at least I haven't used it in any of my typhoid patients.
It doesn't get into the site where it is required. It doesn't have intracellular. So one must be extremely cautious that our antibiotic arsenal for typhoid is, gradually, reaching near zero. Imagine a patient of typhoid fever where it is MDR typhoid, fluoroquinolones are not working, ceftriaxone resistance is reported, and we just saw a few reports of azithromycin resistance. Such patients will require only carbapenem. And as I said before, the moment you expose gram-negative pathogens to carbapenems, they learn to develop carbapenemase. So imagine there is always a risk of going back to pre-antibiotic era with CFR of 15 to 20% for illnesses like typhoid, which we apparently have conquered with use of antibiotic. And that's why, my dear friends, please refrain from using azithromycin for every sore throat, every cough, cold, every ear infection, and every infection or every fever. Azithromycin should be respected and should be used very sparingly. Now, Rajkumar, what about dual antibiotic therapy for enteric fever? Because I came across this paper where they compared dual therapy with combination therapy, though in adults, and they said that the outcome was better, and these were the advantages. It shortened the fever effervescence by 12 hours, faster bacterial clearance, and it was used in both uh, outpatient and inpatient, and led to shorter hospital stay and reduced pathogen carriage. And they propose that this exposure to dual antibiotic may help prevent development of AMR. Do you agree to this theory, and do you prescribe dual antibiotic for typhoid fever?
For typhoid, sir, a monotherapy is still effective, though effervescence may take time. As a moment of de-escalation, when you want to discharge a patient and manage as outpatient, you can consider switching over to azithromycin, but using a dual antibiotic does not have any benefit. And again, we need to see why we are using a dual antibiotic. If you want to reduce the duration of fever by just 12 hours, you want to reduce the stay by just 1 day, it doesn't make a difference. And for that, exploiting two drugs together, it's not ideal. So monotherapy is always recommended.
Okay, so very well said that we would not resort to using dual therapy. I think in the interest of time, I'll stop sharing my slides and let's take on some views and some questions. Let me utilize this opportunity of presence of Dr. Bala and Dr. Prajapati here on the platform. And I would specifically ask them this question that there is a proposal that if you expose salmonella to two antibiotics simultaneously and shorten the, presence of bacteria in the bloodstream, the resistance development can be lowered. What are your opinions, Dr. Bala?
Yeah, first of all, Dr. Vijay, there is absolutely no strong evidence to support dual antibiotic therapy for enteric fever till now. The biggest problem is the moment we start recommending dual antibiotic therapy, saying it is going to be helpful, this dual antibiotic therapy will be given for Vidal positive fever and not for enteric fever. And every fever, 5th day, people will start to dual antibiotic therapy. It will only worsen the antibiotic resistance. There is no role. In fact, we published in 2004, we compared, in our own hospital in around 2003-4, different units were practicing different antibiotic protocols. In our unit, we were giving only one antibiotic for enteric fever. Some units, they were giving dual antibiotic therapy. We compared the duration of fever and the duration for defervescence. It was not statistically different. So there is enough evidence that dual antibiotic therapy, you want to reduce fever by 12 hours by giving two antibiotics, but you're going to worsen the resistance. That's one. The second issue which was discussed is cotrimoxazole. See, the problem with cotrimoxazole is that it is not the drug of choice. It's not the drug, it's only an alternative drug. If you want to consider cotrimoxazole in a patient in whom there had already been exposure to cotrimoxazole, no allergy, yes, you can consider. But otherwise, the duration of defervescence of cotrimoxazole in most published data has been longer than for azithromycin or for ceftriaxone. And you start cotrimoxazole straight away for enteric fever, you end up having Steven Johnson, it's a problem. Right? So let us stick to only monotherapy for enteric fever as of now. And in fact, even meropenem failure, you quoted Balaji's paper of azithromycin failure. There are many papers of meropenem failure. So we'll be left only with aztreonam. So I think we should stick to single drug therapy rather than dual therapy. And one point we must remember is that you can extend azithromycin therapy for beyond 7 days, even 10, 14 days. There's no harm.
After the fever defervescence, it's better.
Yeah.
Agreed.
You can increase the duration of azithromycin. It's not, for example, in Legionella, you give azithromycin for 14 days. Like that in enteric also, if you are having a child who takes a very long time for defervescence, you can use azithromycin for a longer period.
Thank you so much, Dr. Bala. And Dr. Prajapati, you have anything other than what Dr. Bala has said to add in Salmonella? Because you have seen n number of cases of enteric fever, culture-borne enteric fever.
I think Dr. Bala well said. And the very first question to Dr. Vijay, that what you want to achieve by the two antibiotics?
Absolutely, absolutely. See, only thing is,
There is no any specific, I will say, achievement.
yeah,
And for very simply answer, I think very clear message should go to our friends. At present, I think sporadically at certain places, yes, we have seen the septragon resistant, maybe due to various reasons, but I think we should not make it generalized. I
yeah,
think in our daily practice, still, if I quote from my own institution, we have more than 500 cases blood culture positive salmonella in last few years. And believe me, not a single case we have come across the septragon or septic register. So I think simply from that experience that, of course, at certain places, at the same time, what you said in Baroda, they face the problem due to certain regions. And now again, there is no problem of septragon resistant in Baroda itself. So probably maybe some other regions, we should not make it generalized for our practice.
absolutely. It'll be an incorrect message to go
Vijay,
across this
Vijay,
platform.
just
Yeah,
Vijay, one more comment.
yeah,
You asked a question on amikacin.
yeah.
Pediatricians should remember a very important fundamental fact. Aminoglycosides don't have any effect on intracellular organisms
Absolutely.
and also on staph aureus. These
True.
two things. In fact, we have used, you must remember, in 1980-90, WHO used to recommend protoxylin and gentamicin for staphylococcal pneumonia.
I have
That is
used it for
two diseases, aminoglycosides should not be used. One is enteric fever, Shigella, and Staphylococcus. The reason is, the aminoglycosides do not have any effect on any intracellular organism. In fact, good microbiologists like Dr. Nivedana will not give a report of salmonella sensitivity to amikacin. A good microbiologist should not give.
Yeah.
The pediatrician should not think that gram-negative organism, synergism of a beta-lactam and aminoglycoside. It doesn't exist for Salmonella, Shigella, and E. coli. You should not be using aminoglycoside for Salmonella and Shigella because they are intracellular. Your amikacin will not do anything at all.
Well, so I cannot thank enough my expert panelists, Dhanalakshmi, Rajkumar, Nivedana, and Rashna, without whose input this session couldn't have been, go on like this for more than 1.5 hours. In the interest of time, I had to cut the session short. Chetan, I tried my best to start from simple otitis media and go on to cover ICU cases with newer investigation modalities and the newer antibiotics. I know AMR is something which cannot be discussed in 1.5 hours time, but we tried our level best. And I once again thank all the panelists and the PIDA for giving me this opportunity. And now I hand it over to Chetan to take questions if there are any in the chat box. Before that, I would just want to let's not discuss this on this platform, but I'll have one-to-one talk with Bala and Baldev Prajapati on the concept of early clearance to prevent development of AMR in Salmonella. We'll talk it in person, as well we'll end up sending wrong message on this platform. Okay, fine. Over to you, Chetan. Thank you, Dhanalakshmi, Rajkumar, Rashna, and Nivedana. It was wonderful.
Thank you, sir. Thank you.
Thank you, sir. Thank you, sir. It was wonderful.
Sir, thank you so much. I think none other than Dr. Vijay Avile can do justice to this topic. And that fact was very well known to Dr. Bala, sir. And that's why he gave this responsibility to Dr. Vijay Avile. And of course, fantastic panel, fantastic force who were at the rescue for many of the difficult situations. Now, sir, there are so many questions. We'll have to go through very fast because there are few in this Zoom also, and there are many in YouTube also. So the question, I'll just read it out faster. There's Bala sir's comment that purulent otorrhea is not viral.
Agree.
Okay?
Yeah.
Purulent otorrhea indicates.
Vijay, 1 minute, Vijay. The reason why I put that, the moment you see pus in the ear, that indicate that the drum is perforated and it is bacterial. There's no question. If underlying infection could have been viral, unlike an effusion, which can occur without bacterial infection, which can also resolve once there is purulent otorrhea, that indicate that the drum was ruptured and definitely there had been bacterial superinfection.
Absolutely.
Unless it is a chronically discharging ear, in an acute otitis media, if pus is coming out, it is an indication for antibiotic irrespective of the age or other parameters of severity. That's what I
Absolutely.
wanted to.
I cannot agree more on what you say, Dr. Bala. The problem here in the confusion arises because our guidelines talk about mild disease, unilateral disease, hold on, don't start an antibiotic. Mild disease in child above 2 years, unilateral disease, hold on. We have not clarified there that autouria is an indication to start antibiotic. So I totally agree with you. Go ahead, Chetan.
Sir, if it is a purulent discharge, if it persists even after first you gave amoxicillin, you gave amoxiclav, and after that also if it persists for more than 1 or 2 months, what exactly to be needed?
That is an indication for referral to an ENT surgeon.
And what is expected from them?
No. They will have to look for complication like cholesteatoma or a dangerous perfusion or an associated mastoiditis or a complication.
And
I
what
don't
are
think,
And
as a
another predisposing
pediatrician
factor also.
Pediatrician also should be aware of the possibility of something like immunodeficiency, LCH, HIV, and so many other things.
We had a
So
child.
I don't think if it is a chronically discharging ear, it could be anything from a foreign body to immunodeficiency to LCH.
Absolutely.
It's a complication.
So, Chetan, another thing, apart from chronic autouria, it is recurrent autouria which bothers people. So, in that case, one needs to try and figure out if there is an underlying predisposing risk factor. Hypertrophied adenoids.
Yes.
To just give an example earlier. So that needs to be. So there is a word of caution that one is otoscope is a must. And beautiful otoscopes are available which can be connected to your iPhone or any smartphone, and you can literally view the drum beautifully well. So I would make an appeal and urge to every pediatrician to buy that otoscope, which costs 7,000-8,000, like your well-challenged regular otoscope. It makes life very easy and simple. The otoscope is very 3.5 to 4 millimeter diameter. You can really visualize the drum very well. Number one. Number two, a word of caution before jumping to using high-dose co-amoxiclav. And Dr. Bala would agree that we have made a consensus to simplify the algorithm that treat most of the otitis is pneumococcal, start with standard dose. If it fails, you switch to high-dose co-amoxiclav, provided you have made a proper diagnosis, given adequate dose duration, and you have ruled out your otitis conjunctivitis syndrome, or there is no risk factor like exposure to beta-lactam in the past 30 days. Go ahead, Chetan.
Vijay, very good message from you and Dhanlakshmi on high-dose amoxiclav. Very, very lucid explanation Dhanlakshmi gave for that. Very nice. I just wanted to add one more point for the benefit of practitioners. This high-dose amoxicillin clavulanic acid has no place in the treatment of LRI, pneumonia, or sinusitis.
I think she made it very clear that 40 per kg is more dangerous.
Unfortunately, pharma companies will promote it for otitis media, sinusitis, and all respiratory infection. I'm afraid it doesn't have a place in the treatment of pneumonia or even in sinusitis. Restricted to only for otitis media as a second line therapy as of today.
Absolutely.
Dr. Balasa mentioned that receipt of recent antibiotics, how many days should be considered for stepping up? Many times only 3 or 5 days therapy is given. How do we decide?
30 days, in the last 30 days.
No. The problem is, see, this is based on the AAP recommendations. In US, everybody will give antibiotic for 10 days. Okay. And then if it recurs, yes, you go for the second line. In India, 30 ml bottle, they give for 2 days. They come to you after 15
1 or
days.
2 doses, low dose. I don't think that.
I believe, Dr. Bala, that there is no study on such thing, but I guess that anything which is used for more than 48 hours should be considered a significant exposure. More than 48 hours. I mean, this is just a guess.
This is an India specific problem.
I know.
We'll have to individualize.
I know.
And adjust according to the conditions prevailing.
Absolutely.
Dr. Jog sir asked how long to wait and say no improvement. I think we mentioned 48 to 72 hours.
I think almost 72 hours.
72 hours.
Yeah.
Balasa mentioned worsening during or failure to improve after 48 to 72 hours. That's the answer I think he gave.
That's from up to date.
Yeah.
Okay. Fine. round pneumonia with leukocytosis pneumococcal unless proved otherwise.
Cannot agree more. Yes.
Okay. So Palaniraman asked, why not injection cephalosporin? I think in respect to that, Palani is also there.
Sometimes it is not available.
No, it's mostly not available. In fact, it's very
Right.
difficult to get cefazolin in Chennai. The
Yeah.
other problem with cefazolin is again maintenance of IV line.
True.
Two anti-staphylococcal drugs, cloxacillin as well as cefazolin, notorious in causing thrombophlebitis. You'll have to change the line almost every day.
Agree.
But it's a good option as far as this.
Very good option.
Yeah.
MSSA is concerned, yes.
Yes. There is with culture report of MSSA, cloxacillin should be started.
Availability is an issue. I agree with the
Baldev sir.
comment.
Okay. And
I think that was with a reference to the discussion. That once you have considered staphylococcal, you have consider MRSA and started suppose ceftriaxone and vancomycin. But once you get the report that it is MSSA, best way is to come down to the cloxacillin.
Yeah.
Because vancomycin is inferior to cloxacillin in the case of MSSA. That's the point.
Absolutely, absolutely.
Correct.
And sir has also mentioned the abdominal infections are usually polymicrobial, and that's the
No. The reason why I put that in the list of drugs given in the slide, cotrimoxazole and doxycycline they're not there for MRSA. They are very good drugs for MRSA, have susceptibility.
Agree.
Only thing is, they are not recommended for bacteremia. Cotrimoxazole and doxycycline are good drugs when you have something like intra-abdominal infection where you have grown MRSA, or you have had a skin and soft tissue infections where there is MRSA. They are very good alternative drug. There is enough data even in appendicitis. You can use doxycycline if you have Staph aureus, which is MRSA. That's what literature says. They are good alternative drugs. You need not go in for tigecycline. You can go in for tetracycline or doxycycline or even cotrimoxazole. But both of them should not be used if there is bacteremia.
Dr. Jalil has asked, many labs, they don't mention about BP, that is breakpoint, and MIC. In that case, what should we do? Same issue is reporting hospital-acquired as well as community-acquired MSSA, MRSA, and how should we manage?
So community-acquired and hospital-acquired, there is no mention. You have to infer it from the culture and susceptibility. But BP and MIC, most of the labs do not mention breakpoint, but there are softwares which are, the apps which are available. I would request Nivedana to comment on this.
So the labs are, if they report the MIC, they are supposed to report along with the breakpoint, sir. Otherwise, it doesn't make any sense. And another, I also urge the labs that if they report by distribution testing, to not give the zone sizes. It confuses doctors completely. So they can just correlate with the data, do the background work, and they can just simply report it as sensitive, intermediate, or resistant alone. But if they report the MIC, they are supposed to give the breakpoints, because even the microbiologists can't remember the MICs for all. So without giving the breakpoints, it doesn't make any sense at all. Either report with the breakpoint, the MIC, or just simply report as resistant or thing for both the distribution and MIC.
Somebody has mentioned in the YouTube that if report mentions directly as susceptible, intermediate, or resistant, that means ideally microbiologists must have already calculated all this.
Yeah.
So it is their duty to do that, actually. They are supposed to do that.
It's either the microbiologist who does it or the machine which does it and gives you the report. Am I right, Nivedana?
Sir, always the microbiologist should be above the machine, sir.
Yeah, in fact, a good microbiologist like Nivedana, they always help us by giving a report which we understand. Instead of mentioning MIC, breakpoint, etc., they should always below the report which drug they would suggest, which drug they would recommend for particular clinical scenario. And from the clinician's point of view, when you can't understand the report, when you can't decipher the report, best is to go to the microbiologist's office, sit down, ask them to take a class, and finally ask them the most important question: which antibiotic in the clinical situation. That's what we should do.
But with use of Vitek and most of the laboratories giving MICs now, and then you have multiple antibiotics which are workable in a given patient for a given pathogen, it is worthwhile now start learning and practicing MIC and breakpoints. We tried our level best to simplify it today. Nivedana, you are great. And with
For serious and ICU infections like streptococcal meningitis, it is prudent to give the MIC and breakpoints, sir. Whereas for enteric fever, it is more than sufficient if you're going to give the sensitivity to the standard drugs, but just sensitive or resistant. And I also urge the microbiology labs not to report sensitivity to aminoglycosides for Salmonella and Shigella.
Yes.
Like just to reiterate for what Dr. Bala had said.
On a similar note, for once they grow something like group A beta hemolytic streptococcus from the throat swab, they should not be giving reports about azithromycin, amikacin, etc. They should only say sensitive to penicillin and be done with it.
And they should not even report other pathogens if at all they grow from.
Absolutely.
Yeah.
I think this in this regard.
Reporting, sir.
Okay.
Yeah,
somebody has mentioned the dose of azithromycin in group A streptococcus is higher.
It is 12 milligram per kg, but why use azithromycin at all?
Exactly.
Unless it is allergic. There is no need to. In fact, I have seen enough number of cases where people have given azithromycin outside and symptoms not improving, culture still growing. Okay. It's better not to use azithromycin for sore throat.
And regardless of the dose used, there is a dose-independent resistance. Nearly 1/3 of cases are resistant to it.
Almost, I think 30 to 40% resistant.
30%. Dr. Charul has asked, what are the indicators or red flags of going upfront PIPTAs in UTI with ESBL E. coli? I think there are, anyone can take.
Dhanalakshmi mentioned that. Dhanalakshmi,
yes.
Repeat.
Where you suspect ESBL E. coli in UTI?
Yeah, we can use that unless very young infant, when there is no bacteremia, we can very well use piperacillin and tazobactam. When you expect a bacteremia, child is having shock, sepsis, child is going to ICU, hemodynamic unstable, go for carbapenem.
And even the previous UTI, second episode, with the past history of UTI also, that will cause chances of ESBL getting this time.
Yeah. See, most of the isolate, 70 to 80% are now ESBL only.
Yes, because
piperacillin tazobactam, once you give a sensitive isolate, de-escalate. See, anyway, it is an end organ damage causing disease. So don't take a chance. So upfront cover for ESBL, then if possible, de-escalate.
And many times, like knowingly, unknowingly, the patient has received the antibiotic, which is UTI even not diagnosed, but given antibiotics.
We have done a study, sir. No, so we have just analyzed. So that culture discordant antibiotic, like for example, ESBL received ceftriaxone. 1/3 at follow-up had a breakthrough UTI. They came back with recurrences. So unless you have a close follow-up, the mother is well educated, she understands what you are talking, she will come for regular follow-up. If you had that confidence only, you continue the same antibiotic. Otherwise, it's better to go for a culture sensitive.
Well said.
But this is regarding ESBL E. coli in UTI. Some of the labs, they still report it is sensitive to cotrimoxazole. And the physician is tending to...
Yes, sir. If it is sensitive, very well we can use it, sir.
Both cotrimoxazole and quinolones can be considered if your lab gives you a report of ESBL sensitive. They are very good alternative oral drugs.
Yes.
Yeah. In fact, you can either see the alternatives when you have ESBL UTI include amoxiclav, oral, or in a rare case, amikacin, intramuscular, you can follow it up, or cotrimoxazole or quinolone. Last but not the least, phosphomycin as a last alternative. And somebody had put in the box, what about ferropinum? Ferropinum is
not for pyelonephritis, only for cystitis.
No. As an alternative drug, if you have lab sensitivity, I'm saying.
But I believe Dr. Bala,
the lab is sensitive.
phospho and nitrofurantoin should not be used.
Should not be used for pyelonephritis, only for lower UTI it should be used.
Lower UTI, not for pyelonephritis. Not for, I said USBL UTI, not pyelonephritis. Then ferropinum is unferropinum. Is a useless drug. It should never be used. It should never be used. And in fact, if you look at the world statistics, China is #1 selling country, India is second, Okay, I don't know how it's being sold. Adult physicians are using it, has no place in pediatric UTI as of now. We have many other good drugs, and it's not a carbapenem at all. It's only a penem.
We almost completed all the questions. I'll request our chairperson, Dr. Darur, to give a comments.
Excellent. I should compliment Vijay
Yes, sir.
Vale and the team. Excellent. Hats off, Vijay. Hats off to all the four young panelists. Wonderful session. Thank you. Over to Darur.
A good teacher will make the students learn better and understand. That is what I have seen today in Dr. Vijay Avale. And it is said that antimicrobial resistance is a risk associated with antibiotic overusage. It's not the appropriate, it is the overusage which is destroying it. Overprescribing of antibiotics is associated with an increased risk of adverse effects, increased medication, and self-limiting conditions which are going to disappear are being put to wrong usage. 90% of the prescription are for respiratory tract infection, most of which are viral. The antibiotic usage, misusage is in the respiratory infections. Multifaceted interventions are needed. One among them is making all the doctors conscious about the reasons and the choice of prescriptions that we are trying to do it. MRSA kills more than the people put together, than the diseases which are caused by emphysema, HIV, AIDS, Parkinson disease, and homicides in the USA. This is a statement given by somebody. And lack of new drugs active against multi-drug resistant gram-negative bacillus, especially against those produce carbaminases, is going to be the eternal problem for the entire future doctors. Drug resistance is a phenomena which previously used to be said that it is poor and developing countries, but now it is the entire world is suffering with this. To limit the drug resistance and others, we have promised on the day of our installation that we will put in all our efforts to reduce it. This is an effort by our team, 11 team, and I congratulate everyone who are associated and who took part in this program. Thank you.
Thank you so much. At last, Dr. Yashwant Rao, please, Thanksgiving.
At 11:20, I thank Dr. Balasubramaniam sir for taking up such a wonderful program. Nobody left. Dr. Dhanlakshmi, I thank Dhanlakshmi, Dr. Rajkumar sir, Rasna madam, and Nivedana, and patient hearing by all the viewers, and really Dr. Vijay Avale sir and others for being an active part, deciphering each and every aspect wonderfully. Thank you all.
Thank you and good night.
Thank you,
Good
everyone.
night.
Thank you.
Good
Thank
night.
you. Good night.
Good night.
Good night. Thank you, sir.